Welcome to Clinical Minute. Marina is an 18-year-old woman who has come to see you after receiving a positive result from a home pregnancy test. Her last period was 9 weeks ago. She is in your office today to verify that she is pregnant and to discuss her options for termination. This is Marina's first pregnancy. She is a full-time student and currently lives with her mother. Marina says that after considering her options, she doesn't want to have a baby now and would like to have an abortion. She also tells you that she has discussed this issue with her mother, who supports her decision. You begin by gathering a thorough medical history from Marina and collect the following information: lab work to confirm pregnancy, determine Rh status, hematocrit, or hemoglobin as necessary. Determination of gestational age by last menstrual period, ultrasound, or physical exam. Marina's lab work reveals no concerns, and the gestational age of the embryo is determined to be 7 weeks. With these results, you counsel Marina about her abortion options. You explain that this clinic is staffed by nurse practitioners and nurse midwives, who are trained and able to provide medical abortion. Marina expresses interest in medical abortion, so you explain the regimen to her. She will take the first pill, which is 200 milligrams of mifepristone, orally at the clinic. The second medication, 800 micrograms of misoprostol, will be taken at home 24 to 48 hours later. The misoprostol is inserted either vaginally or buccally, which means placing the pills in the space between the teeth and the inside of the cheek. She will experience cramping and bleeding shortly after taking the misoprostol. There is a wide range of cramping and bleeding experienced by women who have a medical abortion. Some women experience heavy bleeding for several hours with blood clots the size of lemons. Most women experience bleeding heavier than a menstrual period. Other women have much lighter bleeding. For some women, the cramps are intense, but others experience only mild pain from cramping. Most women are somewhere in the middle. She can take ibuprofen or other medicines provided by the clinic to manage her cramping pain. In order to expel the pregnancy, the uterus must contract and the cervix must dilate slightly. For over 90% of women, the pregnancy will pass within 4 hours of taking the misoprostol. For a small number of women, it can take up to 24 hours. You let Marina know that this medical abortion regimen is highly effective for most women. In terms of follow-up, you will schedule a phone call with her in about 1 week to ask a series of questions to assess whether she passed the pregnancy and how much she is bleeding now. She also has the option of returning to the clinic in 1 to 2 weeks to check that she is no longer pregnant. However, she can call the clinic at any time if she is bleeding very heavily or is worried and wants to speak with a healthcare provider. When it was approved by the FDA in 2000, the regimen for medical abortion involved 3 office visits with a physician. The first visit included counseling and a 600 milligram oral dose of mifepristone. 2 days later, the patient would return for a 400 microgram oral dose of misoprostol. The third visit was a follow-up 2 weeks later. Since then, scientific research has supported the use of modified medical abortion regimens that are as effective, less costly, and provide numerous advantages to women. The current evidence-based standard of care for medical abortion includes a lower mifepristone dose of 200 milligrams, home administration of the 800 microgram misoprostol dose, which can be taken either vaginally or buccally, a single visit to a healthcare provider. Unless an in-person follow-up is necessary, the patient only needs to visit the provider to receive the medication. There are several ways to confirm that an abortion has been successful. Current evidence-based methods of follow-up after medical abortion include a clinical examination, ultrasound, a telephone interview with a low-sensitivity pregnancy test, a semi-quantitative pregnancy test, or quantitative serum HCG. The clinic will tell the patient which method they use and if she needs to return for a follow-up appointment to confirm that she is no longer pregnant. In the United States, there are several categories of health professionals who can provide medical abortion care. Eligibility is determined by state law as well as the regulations of medical and/or nursing boards. Currently, 39 states limit the provision of medication abortion to licensed physicians only. In virtually all states, even those that require a physician to administer the medications, advanced practice clinicians conduct the majority of the workup, assessment, and in some cases the counseling for medical abortion. Advanced practice clinicians or nurses who are trained to competence also frequently perform the follow-up examination or telephone assessment. The State Center at the Guttmacher Institute's website is a helpful resource for detailed information on legal requirements for medical abortion. There is ample evidence to demonstrate that advanced practice clinicians, including nurse midwives, nurse practitioners, and physician assistants, can be trained to provide safe early abortion care. However, the FDA allows only licensed physicians to order and receive mifepristone. Collaborative arrangements will need to be made to acquire this medication in clinics that do not employ a physician. To provide abortion care, all clinicians must receive training to competency that includes the prevention, recognition, and management of complications. Advanced practice clinicians are often employed in many healthcare settings and frequently provide comprehensive healthcare. Because physicians and surgical facilities are scarce in many rural, remote, or low-resource areas, advanced practice clinicians who practice in those areas and are trained to provide medical abortion fill an important gap in the provision of reproductive health services and can greatly increase access to abortion care. Both the American Public Health Association and the World Health Organization have issued policies and recommendations that clearly state support for the provision of medical abortion by trained advanced practice clinicians. Expanding the pool of clinicians who can provide medical abortion may improve the lives of women and their families by reducing cost, travel, and other barriers, and increases the availability of early abortion care. To implement medical abortion care by advanced practice clinicians as part of your practice, start by checking your state regulations. It may also be a good idea to consult with an attorney familiar with healthcare laws and regulations. Also, you may consider becoming an advocate to change public policy and health systems to expand the provision of abortion care by advanced practice clinicians. Marina decides to move forward with a medical abortion at your clinic. You make sure that she understands what to expect. As required under federal law, you provide her with the booklet Medication Guide and obtain her signature on the patient agreement, which describes the FDA-approved regimen for medical abortion. This regimen differs from the current evidence-based regimen because researchers and clinicians have discovered more effective ways to administer medical abortion since the FDA clinical trials were completed in the mid-90s. In addition to the patient agreement, you also have Marina read and sign your clinic's consent form that explains the evidence-based medical abortion regimen that she will be receiving. You sign the patient agreement and record the serial number from the package of mifepristone in her patient record. You review Marina's medical records and answer her questions. You then provide her with the mifepristone and misoprostol tablets. Marina swallows the mifepristone immediately under your supervision. She will take the misoprostol at home within the next 24 to 48 hours. You provide Marina with discharge instructions and confirm that she understands what to expect over the next few days. You tell her to contact the clinic if she has any questions or experiences any of the following: heavy bleeding with dizziness or lightheadedness, soaking 2 pads per hour for 2 consecutive hours, flu-like symptoms, fever, or chills occurring after she takes the misoprostol, fainting, severe abdominal pain or severe cramping that is not relieved with ibuprofen or other pain medicines given to her at the clinic, or failure to get her next period when expected. You inform Marina that her next ovulation could occur anywhere from 8 to 36 days after the abortion. This means that she could become pregnant as soon as a week after she takes the medications. You discuss contraception options with Marina and let her know that she can start hormonal contraception immediately or have an IUD inserted after the abortion is confirmed. Marina says that she would like to start on oral contraceptive pills. You provide a prescription for the pills and also dispense emergency contraception with instructions for use. Marina thanks you and prepares to leave. You schedule a follow-up phone call in 1 week, and Marina agrees to get in touch with the clinic if she has any complications, concerns, or questions.